Good morning, everyone. So last Tuesday night, we talked about the fact that addiction is a disease. It's not a choice. It has nothing to do with willpower, ethics, morals, and it's not a behavior. It's an actual disease, and in fact, it's a disease of the brain. We've known this for many decades, and in fact, the American Medical Association put out a statement in 1981, which was probably before some of you were born, that stated we have more scientific evidence to know that addiction is a disease than we have for some common disorders like hypertension. What we covered last Tuesday night was how the brain changes its functional structure in such a way that the individual no longer has a choice about whether or not they're going to use mood-altering substances. And so if you ask your loved one who suffers from this disease to just make a choice, to just stop using, that's really a futile request because they don't have a choice anymore, not in the way that you think of choices. And I want to quickly review that principle before we go into today's lecture, which is the abnormal physiology, or the way that the brain changes its actual physical structure when someone has the disease of addiction. So first, let's review last week's lecture. And we're going to do that side view of the brain. This is where you basically take an axe, split my head down the middle, and we're looking at it from the side. And we talked about how there are different parts of the brain that do very different things. But what we focused on was this bottom part of the brain, commonly called the limbic system or the basal ganglia. It's the more primitive areas of the brain, and many of the functions that occur down here are subconscious. And we talked about the frontal lobes, the socialization center, the part of your brain where you have all that information that you use to determine what is right versus wrong, good versus bad, acceptable versus unacceptable, and even to a great degree, safe versus unsafe, okay? That's the part of your brain you use when you're making a decision and when you're doing something by choice. So when you make a choice, you basically use all your cultural norms and say, what should I do? What's going to have the best outcome according to what I believe is right, good, acceptable, and safe, okay? In addiction, a more primitive part of the brain, particularly the nucleus accumbens, the pleasure center, the reinforcement center, the part of the brain that gets massively overstimulated, stimulated to a very abnormally high degree by the mood-altering substances, is repetitively, because addiction is a habitual use of a mood-altering substance. It's getting stimulated and stimulated and stimulated, and instead of the frontal lobes being the dominant and most active part of the human brain, and therefore in control, if you will, this primitive part of your brain that cares about only one thing, and that is being stimulated, gets in control. And nothing stimulates it more than mood-altering substances. We talked about the natural stimulators of that part of the brain being what? Who remembers? Sex is definitely one. What's the number one salient natural stimulator of the primitive? Water. Okay, water is the most life-limiting ingredient on Earth. You got about 3 days without any fluids and you're a goner. Okay, food, 2, and then we talked about sex and sleep, whichever you've had the least of recently. And then some other things, right? Those are the things that are supposed to stimulate this primitive part of your brain so that it will make you want to repeat those behaviors constantly because they perpetuate the individual and the species. But remember, mood-altering substances massively stimulate that primitive reinforcement center, way more than the naturally salient things. And so when that happens over and over and over again, this part of the brain, including all the pathways down here, starts to become dominant in regards to your use of a mood-altering substance. So while your frontal lobes are saying it's not good to drink and drug, it's not acceptable, it's not safe, And all your frontal lobes tell you that while you have the disease. Your frontal lobes get overruled because your reinforcement center, your pleasure center, is more active and more dominant during the disease of addiction. And that's why, even while you're saying, I have to stop drinking and using, while you're saying that, you often find yourself getting up and walking out the door to go get more. Who experience that kind of phenomenon? Okay? So when you say, make a choice, just choose to stop doing this, that's not how it works in the disease of addiction. And that's why everybody needs to start thinking of addiction as a disease, not a behavior. The behaviors occur as a result of a disease process on the brain. Now today, what I want to look at is how the actual structure of the individual brain cells changes that explains why the disease of addiction is and must be progressive. Without interruption, it gets worse. And it has to. And the way to show you that is to show you what happens with a mood-altering substance at the individual brain cell level. So we're going to take a look at a couple of brain cells right in that pleasure center, the nucleus accumbens. Okay, so these are two brain cells in that particular part of the brain. Before we do that, I just want to talk about brain cells in general. So we call brain cells neurons. In your head, you have hundreds of billions, maybe trillions of brain cells. And each brain cell looks roughly like this. And I mean very roughly, because as you guys know, my artistic skills are not great. Whoops. So you have a body of a brain cell, three-dimensional, not two-dimensional, three-dimensional, called a soma. And then you have all these tentacles coming out. And they don't just come out this way. They come out towards you and they go back that way. And they're very circuitous, actually, but that makes it too hard to draw. And each tentacle connects with the tentacle of another brain cell. So each individual brain cell, which there are hundreds of billions to trillions, has multiple connections and multiple potential connections to other brain cells. Now these connections are called synapses. And the brain is essentially an electrical organ. In its most simplistic terms, it works by generating an electrical current, which we designate by the broken line. And that electrical current comes down one of these tentacles. We call these dendrites, axons and dendrites. And then there's a special process that occurs where one brain cell's dendrite meets another brain cell's that causes that electrical current to then be generated in the next brain cell. And then it goes out another dendrite or axon. Okay, electrical current. And at some point, if you do enough of these in a row, you have what's called a pathway, a brain pathway. And the way our brains work is that when you are repeatedly exposed to a piece of information, it fires the exact same pathway. And that pathway then becomes ingrained. It becomes a permanent pathway. And that's how you retain information. Okay, so all the things that you know, all the behaviors that you've established, your ability to do a particular physical action like swing a bat, you have ingrained pathways that you develop by repeating that behavior. That's important in addiction, yes, sir.
Do those pathways, I mean, you say you're exposed to it a number of times. Each action can be different. Some will take longer to form a pathway than others.
Sure. The more complicated the action, it may involve multiple pathways. And then you have differences in the rate in which people's brains will develop an ingrained pathway. And they call that neuroplasticity. How quickly can you develop a new pathway and maintain it so that you have learned the behavior or the information? Mood-altering substances, have there any other questions about this before we move on? Mood-altering substances have their effect essentially right here at this connection between two brain cells called the synapse. So what I want to do is blow this up, take a look at it to explain how mood-altering substances have their effect and therefore why the disease of addiction is progressive without external interruptions. So we have the body of one brain cell here, and its dendrite coming out. Body of the next brain cell here, and it's okay. Brain cell, brain cell. As we discussed, the brain cell will actually generate an electrical current. Not unlike the currents in the walls here, just much, much, much less powerful. So you can even detect that electrical current. That's what we do in certain studies like an EEG. You can measure that electrical current in the brain. And in the brain, it's not volts like your outlets here, it's millivolts. And that electrical current comes down here and it activates a process at the end of the terminal here. This is called the presynaptic terminal. Don't need to remember those terms. And when the electrical current comes down and there's enough voltage to it, or it's come down enough times, it causes a phenomenon where these vesicles fuse with the end membrane here and release their contents into this space. This is a space. It's called the synaptic cleft. Now, each one of these vesicles, I'm going to use multiple colors today. These vesicles are filled with a chemical called a neurotransmitter. So it's really a neurotransmitter that's being released into this space out here. Who can tell me the names of any neurotransmitters? Guys know the names of neurotransmitters? Dopamine is the neurotransmitter we're going to be talking about here because it's the one that predominates in the nucleus accumbens, the pleasure center, the reinforcement center. Having heard that, you know the names of any other neurotransmitters? GABA aminobutyric acid and glutamate are two of the more common neurotransmitters in the brain. What's the neurotransmitter that you hear about in being involved with depression and anxiety? Serotonin and norepinephrine. Okay. Anyone know the name of the neurotransmitter that nicotine mimics? Acetylcholine. And then you actually have a neurotransmitter in your brain that is essentially your brain's own form of morphine or opioids. Those are called the enkephalins and endorphins. But we're going to be talking mostly about dopamine because it's what predominates in that part of the brain, the pleasure center, the part of the brain that gets you to repeat whatever behavior stimulates it. So the electrical current comes down, causes these vesicles to fuse and release their dopamine. And then on the postsynaptic terminal, there are thousands of receptors. And when enough of those receptors fill with dopamine, it causes this brain cell to regenerate the electrical current. And then it goes out again, crosses another synapse, and maybe one more, and you have a pathway. And that's a thought, or an action, or a movement. Questions about this? Everybody with me? Okay, so now we need to add in some details here. And then we'll add some mood-altering substances. The first detail is that the voltage, the power, if you will, of this current varies. And we're going to arbitrarily choose a 2 millivolt current. And that's important because 2 millivolts will release a proportional amount of dopamine. If it were 4 millivolts, it would release more dopamine. If it were 1 millivolt, it would release less dopamine. That matters because the amount of dopamine released determines how many of the thousands of receptors that are here fill. And how many receptors fill tells this brain cell, the new dendrite or axon, how strong to make the electrical current. And the electrical current has to be the same. Okay? Now let's add a mood-altering substance to these two brain cells. I like to use stimulants because stimulants affect the dopamine directly. But all mood-altering substances, as their end effect, do the same thing that we're going to talk about here when we add cocaine to this brain cell. Now, the rest of them do it through a different pathway, but they all end up increasing dopamine in the nucleus accumbens, the pleasure center. Okay? It's just that alcohol first affects GABA and glutamate, and nicotine first affects acetylcholine, and opioids first affect the endorphin receptors. Okay? So they all do it initially through different pathways, but it all coalesces to the same end effect, which is increased dopamine in the nucleus accumbens. So when we add cocaine to these two brain cells, and a 2 millivolt electric current comes down here, cocaine hypersensitizes the release mechanism. And it makes it release more than 2 millivolts worth. And so it fills more receptors, which tricks, if you will, the next brain cell into thinking it needs to make a more powerful current. And some stimulants, like amphetamines, do something else, because normally all this neurotransmitter has to be broken down, taken back up into the presynaptic terminal, and reassembled and put back in vesicles for the next time a current comes down here. And there's an enzyme called a neurotransaminase that does that, and it does it almost instantly. By the way, this whole process, electrical current, release of neurotransmitter, uptake of neurotransmitter, regeneration of electrical current, breaking down and taking back up of all the neurotransmitter, how long do you think that whole process takes? A short time is correct. About a millionth of a second. Remember, this is very small scale we're talking about. That entire process occurs in about a millionth of a second. There was a discussion between neurobiologists and some other scientists. Our brains are active beyond most people's comprehension. And the discussion was that the neurobiologists think that this process occurs from here to here more times in a single day, 24 hours, than there are molecules on the planet Earth. That is a number so large I couldn't fit all the zeros in this room, but that's how active the human brain is. Okay? Extremely active. Yes, ma'am?
When you use a substance, do all of the brain cells, are they all affected like this, or is it only brain cells in the nucleus?
So substances have their effects throughout the brain. Okay? What gets confusing, I'll talk about it briefly because it is important to know, okay, is that while stimulants increase the activity level of all brain cells, opiates, alcohol, okay, they decrease the activity level of all of the brain cells except the pleasure center. We talk about that more in some of the other lectures. But mood-altering substances affect the entire brain. In fact, the other classes, the non-stimulants, have their initial effects outside of the pleasure center. And then eventually it causes the same end effect. Okay?
Is this how we build up like a higher tolerance?
We're getting there. Very good. All right. Too much neurotransmitter is released because the mood-altering substance, cocaine, or any stimulant, makes this release mechanism excessively sensitive, releases too much. It stays out here a tiny bit too long if it's amphetamines or methamphetamine, et cetera. And so you fill too many receptors. So maybe instead of a 3, you actually get a 4 millivolt. This is called hyperexcitation. It's overstimulation. And it's abnormal. But it's also what causes the effect that a person with addiction is looking for, which is what? Euphoria is correct. The high. This is how mood-altering substances have the effect that drives you to repeat it because you want that high, and because there's a part of your brain that thinks you're supposed to repeat this behavior. Your pleasure center, your nucleus accumbens, doesn't know that mood-altering substances aren't doing anything to enhance your survival or the species' survival, like with water, food, sex, sleep, etc. It doesn't know that mood-altering substances don't improve your survival. It's just there to say, if something stimulates me, I will drive you from a somewhat subconscious level, it turns into conscious thoughts, okay, to repeat the behavior over and over and over, like you repeat drinking fluid, eating food, sleeping, sex, all those things, okay? The hyperexcitation means that the mood-altering substances have that effect to a much greater degree than what are considered normally salient factors. Mood-altering substances stimulate your nucleus accumbens far greater and for far longer than the natural things. And that's why they say that drugs and alcohol hijack the human brain. You may hear that term, drugs and alcohol hijack the human brain. All right, now, back to this. This is abnormal. And this is problematic for your brain. And in fact, if it goes on, you'll run out of neurotransmitter in the presynaptic cleft because you're releasing too much and it's staying out too long. You see this clinically where someone goes on a stimulant binge, like uses cocaine or crack or crystal meth for a couple nights in a row. And then they crash and sleep for a week because they've run out of neurotransmitter. Okay? But the brain is not the static organ we once thought it was. In fact, it's capable of making changes. And when it recognizes how abnormal this is, it realizes it needs to prevent this abnormality of hyperexcitation. It needs to get normoexcitation, where a 2 goes to a 2. Because remember, a 2 goes to a 4, and a 4 goes out another dendrite, and then a 4 goes to an 8. Okay, and that may just be one pathway. So how would you guess that the brain prevents this hyperexcitation in the setting of the stimulant?
Would it add more receptors?
If it added more receptors, it would increase the hyperexcitation. So having learned that, now what's your answer?
It reduces the amount of receptors.
Very good. Uh-huh. Neuroplasticity right there. If it takes away receptors, if it literally removes or shuts down those receptors, now even though excess dopamine is released and it stays out there a fraction too long, if there aren't as many receptors there, it won't overfill them. And so now it's going to interpret that, the second brain cell, as a 2 millivolt. You get back to normoexcitation, which equals no euphoria. That's Pathophysiology. Your brain has to change its structure, its physical makeup, to get its functioning, its physiological functioning back to normal. This phenomenon is called what? You already said it.
You get addicted and you
Develop.
a higher tolerance.
Very good.
Okay.
This is the phenomenon of tolerance. Tolerance is the whole problem. Well, it's a big part of the problem. Because what happens is you develop tolerance. Because now if you use that same dose of cocaine, you get nothing. So what do people with addiction do? Because they're being driven up the dosage. All right? You up the dosage, you even get more hypersensitization, greater over-release, slow that enzyme that breaks it down even more. Okay? It goes back to hyperexcitation. Okay? That's abnormal. Brain recognizes it, takes away more of those thousands of receptors. You go back to normal excitation. You see the pattern, the cycle that develops here. That's why the disease is progressive. If there were no tolerance, if the human brain didn't develop tolerance to mood-altering substances, you could start out with a very tiny dose. It would get you high. It would have a rewarding effect. And you would never have to increase your dose. And if you didn't have to increase your dose, addiction wouldn't be the same disease it is. Tolerance is the key feature to why this disease is progressive in everyone. Because if you don't raise your dose, your disease process is going to stop. If you stop overstimulating your pleasure centers, your primitive brain, you will not lose control of your behavior. It won't become dominant in its function over your frontal lobes, and the whole process of addiction won't occur. Addiction is about that functional change in what part of the brain is making decisions. And that's why you see the behaviors change. The behaviors that society sees as so unacceptable and with which society labels people with this disease as addicts instead of people with a disease. It's this tolerance that creates the cycle, that changes the functional structure, that creates the behaviors, that gets us what you know as addiction. Does that make sense?
Perfect.
Okay.
When you get a higher tolerance for a mood-altering substance, does it also change your tolerance for like food and water, so you don't get as much satisfaction out of those, or is it only for that substance?
Relative to the substances, yes. Yes. Now, you still get some stimulation, and your brain's already learned a long time ago that you need food, water, okay? So you don't lose all of your drive, but you do lose some drive. And the classic example of that is the fact that when people come in with opiate addiction, they are almost universally dehydrated. And it's because the part of their brain that reminds them that they need to drink fluids and want to do it repetitively isn't so affected by the lack of fluids anymore. It used to be when your intravascular volume got a little lower, your brain reminded you, go drink some fluids. It's not happening as much when someone's addicted to an opiate that's overriding all that. So in a way, that's true. Not completely, but they almost all come in pretty chronically dehydrated. So yeah, it's a good point. Okay. These two brain cells are very fortunate, and they get into abstinence for whatever reason. No more stimulant. Okay? Therefore, when a 2 millivolt electrical current is generated and comes down and reaches the presynaptic end here, only 2 millivolts worth of dopamine is released. And that enzyme is at full speed and it's breaking it down and getting it out of there in a flash. But remember, this brain cell on the postsynaptic terminal removed a whole lot of receptors as the individual developed tolerance. So now you have a paucity of receptors that fill. And now instead of being overstimulated, it might be massively understimulated. This is called hypoexcitation. And hypo or understimulation equals what, by the way? Withdrawal. So when a person stops using a mood-altering substance after they've been habitually ingesting it and developed tolerance, and they just stop abruptly, they develop withdrawal. Now, you guys know withdrawal as a set of physical symptoms, pretty miserable physical symptoms. And in some cases, like with alcohol or benzodiazepines, dangerous, potentially dangerous physical symptoms. And in fact, rarely, if a person stops high doses of alcohol or benzos abruptly, they can die from it. Delirium tremens, seizures, okay, status epilepticus. Opiate withdrawal, by the way, is not considered in and of itself to have the potential for fatality. It could be pretty miserable, but it isn't considered in and of itself fatal. But all of those physical symptoms, all of them, the sweats, the muscle aches, the vomiting, the diarrhea, the restless legs, the insomnia, those are all a reflection of the fact that it's the brain's functioning that is abnormal. Because it's the brain that controls all of those physical body functions. So all of physical withdrawal is just a reflection of this disease process of the brain. Okay? Now, you know physical withdrawal doesn't last forever, right? And the brain recognizes this understimulation as excessive as well, not just overstimulation. So as you can guess, it's probably going to try and get its functioning back to normal, to a normal excitation. And how would you speculate it does that?
Add receptors.
Bingo. So it begins adding back receptors. And as it adds back receptors, it gets closer and closer to a 2 millivolt going to a 2 millivolt, or a normal current. How long does it take to add back receptors? Well, you know physical withdrawal doesn't last forever. A couple of weeks for its acute phase. How long does post-acute withdrawal last? You guys should have been taught this already in your classes.
9 months to a year.
It can last easily 6 months, 9 months. You know. Studies that they've done to look at brains, not of humans so much, but of animals with addiction, show that it probably takes a minimum, an absolute minimum of 9 months for your brain to get back to normal physiologic levels of current production. And on average, it's probably more like about a year before your brain has added back all those receptors and is functioning completely like it did before it changed itself to try and accommodate the mood-altering substance in the first place. That's why post-acute withdrawal syndrome can last so long. It's also why functioning, because remember, we're talking about the pleasure center and just 2 brain cells, but mood-altering substances affect all of your brain cells. Parts of your brain that deal with emotions and memory, the hippocampus and amygdala, okay? And all the rest of your brain as well. And so if the brain is that abnormal for 9 months to a year, it's going to be very difficult for a person to make rational, reasonable decisions. Like, I don't want to use anymore, because your brain is still highly abnormal. And this is a big reason why the relapse rates for this disease are so high. Relapse is not the exception, it's the norm in this disease. Well, your brain's abnormal for quite a while. And in fact, before you're even through that miserable, substantial physical withdrawal, you're usually out of the most intense treatment period. So when do we do the most intense treatment for your disease of addiction? When you first become abstinent. That's when we'll put you in a residential treatment site to give you lots of external control, because you're not going to be able to control your own behavior. Your brain is a mess. The problem with this concept is that means while you're getting your most intense treatment, your brain is a mess. And so how much of it can we really expect you to retain? How much of it can you absorb, assimilate, and integrate? Well, if you're in horrible physical withdrawal and your brain is at its most abnormal state, not much. And this is one of the reasons that I believe that traditionally the treatment for addiction has been so ineffective. Long-term studies show that people with addiction, it takes 3 to 4 formal treatment attempts, formal treatment sessions before they get sustained sobriety. Well, you couldn't get much out of treatment when your brain didn't work. We're starting to make improvements in that. And what do you think is the single most important factor in being able to improve the outcomes of treatment that we've developed in recent years? The medications that I put you on. Because by using a medication, I can get your brain to function at least much better than it would be without it very quickly. And some of you are on some of those medications. Actually, I try to put all of you on some of them. It's not just, I don't put you on a medication just to get rid of your physical withdrawal so that you're not suffering. I do it for that reason too. We don't want to be cruel and make you suffer. And that old paradigm of, well, if you let them suffer, they'll remember and never want to use a drug again. That's complete nonsense. Okay? We figured out that was wrong when we realized that the terrible pain associated with childbirth will never stop a woman from getting pregnant again. It doesn't work. Your brain is actually structured to forget that misery. Okay? So making you suffer doesn't help the outcome of addiction. But if I get your brain functioning better very quickly, you're more capable of thinking well, of absorbing, assimilating, and integrating new information, developing new behavioral pathways. And that's why we use medications like Suboxone, or benzos if your drug of choice is alcohol, or Neurontin if your drug of choice is alcohol. Let's look at what Suboxone does. So Suboxone, which is really buprenorphine, is the active ingredient. I don't like to use the word Suboxone, that's just a brand name, but buprenorphine is the active ingredient in Suboxone. It causes a little oversensitivity here. So it causes a little too much dopamine to come out for 2 millivolts. It does what mood-altering substances does. The difference is Suboxone will only do it to a limited degree. No matter how much you take, you could take 1,000 buprenorphine, Suboxone Subutex is what it's most commonly known as. And it has a ceiling effect, so you're only going to get a little excess dopamine. And that little excess dopamine may be enough to get, instead of a 0.5, maybe a 1.8. Get it pretty close to normal. And in fact, when you give people Suboxone who come in addicted to opiates and are having horrible withdrawal, what happens? Well, you can relieve their withdrawal. But they also tell you that I just feel like my brain is functioning normally. Their emotions aren't so erratic. Their memory is much better than if they were not given anything to help with the brain function. Okay? And the studies show that the outcomes for people addicted to opiates, when you use buprenorphine products like Suboxone, the outcomes are far greater if you go ahead and use all the other psychosocial treatments that you guys get here as well. It's improving the treatment of the disease, and this is why. Does that make sense to everyone? The difference is you can't get high on Suboxone. You can't get to hyper excitation in a brain that already has tolerance, in a brain that removed all those receptors at any dose. Questions about any of this information? Now, there's a caveat to this that I want to run past you. Let's say that these two brain cells have remained absent for a long, long time. They're back to normal functioning, back to normal numbers of receptors. It's been 1 year to 40 years, 1 year and up, completely back to normal excitation on its own. 2 millivolts go to 2 millivolts. 40 years later, they have the unfortunate fate of being re-exposed to the mood-altering substance. It doesn't work the way it did the first time. It isn't, you take a little bit, you get hyperexcitation. Brain says that's abnormal, I'll remove a few receptors, and then you increase the dose, and that cycle goes on. It doesn't work that way the second time around, because your brain remembers. That's my favorite brain pun. Your brain remembers. And the second time around, it doesn't say, okay, we'll just do this a little bit at a time. It just says, I know this game. You don't gradually develop tolerance and your disease gradually progressive. When people relapse after they've attained full sobriety, a year or more, okay, they develop tolerance like that. And people go back to the dose they left off with when they were at their previous peak use, often in a matter of days to weeks. And the body doesn't tolerate that, and the risk for death is substantial. The other mistake that people make is when they have been sober for some amount of time. It doesn't even have to be that full year. But the brain has been making gradual repairs, and they go back to something like an opiate, like heroin, and if you use the dose you left off with, not realizing your brain won't tolerate that much, you get that one use, and then you stop breathing, and that's it. It's called accidental overdose. Number one cause of death in 18 to 25-year-olds in this country. Okay, guys, any other questions about tolerance, withdrawal, and why the disease is progressive? Great, let's take a break.